Xiaflex, collagenase Clostridium histolyticum, is approved in the U.S. for the treatment of adult patients with Dupuytren's contracture with a palpable cord. Efficacy has been studied in MP and PIP joints. In clinical trials, 44 to 64% of patients had contracture improvement to 0 to 5 degrees of normal, the primary endpoint, within 30 days of the last Xiaflex injection, mean number of injections 1.7. The following cases may not represent efficacy for all patients. Individual results may vary.
Dupuytren's disease is a disease process that affects the fascia in our bodies. We see this most frequently in the palms of the hand and the soles of the feet. The fascia in the palm of the hand is a very important structure. It actually helps divide the hand into different compartments. It anchors the skin in place so that when we grasp things, it doesn't shift on us as we're trying to create torque. But in Dupuytren's disease, due to a genetic predisposition, this fascia becomes diseased. The cells proliferate, they get thicker, they deposit excess collagen tissue, and then that collagen, as it thickens, can also contract. And this causes abnormal cords that draws the finger down towards the palm. We typically see it most frequently in patients as they get older. In men, we see it in the 40s, 50s, and 60s. In women, it seems not to occur until a little bit later on in life, in the 60s, 70s, 80s. The incidence in the Caucasian population is around 3 to 6%, and we see it more in patients with a Northern European ancestry, although it can affect all ethnicities. We're going to be talking about 3 different patients that we had the opportunity to treat with Xiaflex. The first is Mary Jane. She's a patient who's had Dupuytren's disease for a number of years. She actually had surgery on her right hand and had a good correction from the surgical procedure, but vowed never to go through that again. She just had a bad experience, I guess, with the discomfort following the procedure. At this point, she's got 2 contractures, her MP and PIP joint. Our plan is to first address the MP joint contracture and then address the PIP joint secondarily. The second patient I'd like to talk about is Anne-Catherine. She's had nodules and disease in her palms for several years, but it's really only been over the last several months period of time that the contractures have formed, and she's now having difficulty with use of her hand. She has a more severe case of Dupuytren's in that her contracture, fortunately right now, is only affecting her ring and small finger at the MP level. In her palm, her cord is of a Y configuration. She has a pretendinous cord coming up the 5th ray, affecting the MP joint of her small finger, but then she also has a cord branching over to the ring finger, so she has a cord that now contracts both fingers. And the hope is that if we can accurately place that injection well and place it right at the apex of that Y, a rupture will actually allow extension of both fingers. The last patient I want to talk about is named Richard. He's a patient who came to our office looking specifically for Xiaflex. His contractures were progressing, they were getting more involved and interfering with more of what he could do with his hand, but he had underwent a number of surgeries for cancer treatment that really precluded him from wanting any more. Plus, at his advanced age, he really wasn't interested in anything with a more lengthy recovery. Looking at his hands, he had some pretty well-defined cords. On his left hand, he had a Y cord to the MP joints of his index and middle finger. Those then continued up into the digit of both fingers, affecting the PIP joint as well. By targeting his Y cord in his palm, we could cause a release of the cord at that level at the apex of the Y and release both the index and the middle finger MP joints. So when patients first come back to the office ready for their injection of Xiaflex, first we re-examine their hand. We want to make sure there hasn't been any significant changes in their cords or their degree of contracture since the last time we saw them. You can feel your cord starting down here in the middle of the palm. Mm-hmm. And yours goes all the way up to the joint here. And
yes.
Has it been hard to do things with this hand?
Oh, I can't do anything.
Nothing at all?
Well, I can't play with flute, I can't play with piano, and there's a lot of things.
Depending on whether we're treating an MP joint or a PIP joint will depend exactly where we give the injection. So if we can find an area of that cord where it's well defined, not in a nodule, far away from the tendons, and not adhere to the skin, that's where we want to give the shot. And so for the PIP joint, usually that's down by the base of the finger, kind of near the proximal digital flexion crease. It can be a couple millimeters up into the finger, but we don't want to get much further than that because the cord typically starts getting very close to the flexor tendon sheath at that point. So once we've identified the cord that we want to treat and we've kind of picked the best location to do the injection, we just prep that area with an alcohol solution or a betadine solution. The injection we've already reconstituted, but we've kind of mixed up 0.58 milligrams of Xiaflex into a syringe with a 27 gauge hubless needle. Prep the top of each vial to make sure there's no contamination. So just make sure you get all the air out. Put it into this vial. You have to put the medication in, and then you just have to swirl it gently. Sure. Next step is going to be to put this down, open up the next syringe, and then we'll invert this vial and take out the appropriate amount of the drug. Now, before we do the injection, it's pretty common for most patients to develop some swelling in their hand. It may only swell a little bit, or the whole hand may be pretty puffy. Okay. So we should really take your ring off just so you don't have it too difficult to take off the next day.
Good.
And I'm just going to hold a little bit of tension on it so I can feel that cord the best. Now we're going to do the injection I think the best spot will be up in here. And the next step is I just want to kind of feel around your cord and find the best spot to do the shot. And I think we have a really good one right there, so we're going to get that. I'll be able to do it. It's a pretty small needle, but it does, it does sting a little bit.
Yeah.
I'm just going to feel the best spot again. The needle ready here.
Okay.
I'm just going to position your hand again. I hold tension on the patient's finger, so I want to kind of hold that cord under tension. I kind of feel it with my other hand just to make sure I can kind of sense where that cord is, how wide it is. And then with the injection, actually we'll kind of use that needle and put it directly into the cord. Usually the cord is not very deep. You don't have to go very far beneath the skin to hit the cord. You oftentimes will feel, or you almost always will feel, a significant amount of resistance as you go into that cord tissue. So keeping the patient's hand very still, keeping the needle and the syringe very well controlled, you then start putting pressure down on the plunger. And as you inject the medicine into the cord, there's a lot of resistance, and there should be. So you should have a significant amount of resistance on that plunger. We inject a third of the volume into the first spot, and then I basically back the needle out. I try not to take it out of the skin, but just bring it out of the cord, redirect it, and aim it a little bit more proximal back into the cord, feeling that resistance. Injecting a second third of the medication, and then back it back out again and aim distally and put another third of the medication. Sorry. Last spot. Okay.
Are we out?
We're all done.
Okay.
So the idea with this is just to kind of, there's going to be some swelling that you're going to experience tonight. Okay. So make sure you keep your hand elevated.
Okay.
Everyone's a little bit different with how much swelling, but we kind of just put this on there just to keep it comfortable.
Okay.
Help kind of limit your use. Don't want you to I really want you to take it easy with this tonight.
Okay.
Don't try to do any gripping or pulling or lift anything with this hand. Don't try to manipulate or straighten your finger yourself.
Yeah, right.
Some people have actually experienced just inadvertently reaching for something and it pops.
It pops.
So if that happens, that's okay.
It's okay, but
Yeah.
okay.
If you have anything, you can take it. You can actually take this off tonight before you go to bed if you'd like to. Take a look at it.
All right.
It's not uncommon to have, like we mentioned, the swelling, some bruising. Some patients would have some kind of itching response.
Okay.
Although that would be less likely because this is the first injection you've gotten. But that's it. And then tomorrow we'll kind of come back. We'll kind of assess things, see how tender you are. Oftentimes we'll do a nerve block beforehand if we need to.
Yeah.
It all depends on how sensitive you are.
Yeah.
So we'll see tomorrow how it feels. And we'll probably just do it with a little pull without anesthesia.
Yeah.
And if it's not hurting you much, we might just be able to pop it without having to do that.
Okay.
If we need to numb you up, certainly we can.
Then you'll do that.
And just keep it elevated, and
right.
we'll see you tomorrow.
Thank you very much.
You are welcome. When patients come back for their manipulation, we'll first assess their hand again. We'll see if anything happened before they came back in that day, whether they may have experienced a rupture spontaneously. And then we'll also just assess their hands, look for a degree of swelling, bruising, look to see whether or not they have any lymph node swelling or any other issues that we need to be concerned about or to educate them about. At that point, we'll oftentimes just kind of feel their finger, put gentle tension on it to see how comfortable they are. Some patients may not have much discomfort and may prefer to do a manipulation without having an anesthesia. Other patients, if they have more sensitivity, would do better with a nerve block such that we can comfortably manipulate their finger. Nerve block is simply given 5 minutes before the procedure. I try to do that nerve block out of the area of the swelling and tenderness. So we try to stay more proximally in the mid-palmar region or even a wrist level block in order to make sure that they're comfortable. When we're ready to do the manipulation, if patients have any tendency to be lightheaded or have fainted in the past, it'll probably be better to have them lying flat. If they're not likely to have a problem with fainting, we can do it just sitting at a table. If we're going to do a MP manipulation, I'll first stabilize their metacarpal, and then with the other hand, gently grasp their finger, and then slowly concentrate the force right on the cord where we want it to rupture. Sometimes we don't get a rupture right away, and we'll just ease off the finger, let the patient take a breather, relax, make sure that they're comfortable, and then we can attempt another manipulation after that.
Popped.
Yeah, it did.
I felt the pop.
The second manipulation or third manipulation, oftentimes I'll still do, even if we get a pop the first time around, because oftentimes with a second manipulation, we may get another rupture, or we may be able to get a rupture of an adjacent finger if the cords are connected in the palm.
Yeah.
Hear that one?
Wow. That one almost looked like it was a little bit over to
Did you
the
see your
side.
skin right there? It
Yeah,
just
pop.
popped back out.
Yeah.
After we've successfully manipulated the finger and we've gotten to the point where we want, or if the patient has a cord that just won't budge and we feel that we don't want to push any harder and it won't break, we stop at that point. You know, if there's been any skin tearing, we'll put a bandage on, otherwise that's not necessary.
Is the little finger straight?
Yeah, pretty straight. That little blister that I talked about just kind of popped a little bit.
Really?
Yeah. So just a small little area there.
Sure feels a lot better than it did.
Try to straighten it out for me. Look how straight you're getting that, the bottom of your hand here. Go straight. Can you now, I want you to just gently bend down towards your palm. And now straighten out. Just kind of put it.
That middle finger is really straight.
Now put some tension on that. Just kind of push really more forcefully, try and straighten it. Great. The splint that they'll make for you today, they'll basically kind of stretch you out pretty straight.
Okay.
We know that once the swelling goes down, we'll be
Yeah.
able to get it a little bit straighter, and that's why
Okay.
we have you coming back in about a week to 10 days
Oh,
to do
all right.
that. In my practice, we prefer to put everyone into a splint that holds them in their maximally extended position that night, that they will receive that day so that they can sleep in it for the first month or so. So during the follow-up visits, it's important to reassess the patient's hand. Initially right at the 7 to 10 day, we want to make sure that the swelling's getting better, that their range of motion is improving. If it's not, we may want to reinforce their exercises and make sure that they're doing that adequately. But 30 days, we want to look to make sure that their tendons are functioning the way they need to be, that there's no evidence of bowstringing of the tendons, which may signify a pulley rupture. And then we want to reevaluate their hand in general to make sure that their side effects from the Xiaflex is worn off, remeasure their fingers and their joints to make sure that to see if there's any residual contractures, and then to determine at that point if there are any additional joints that need to be treated with Xiaflex. Mary Jane still has a cord affecting the PIP joint of her small finger. We got a great correction of her MP joint, but her PIP joint will still have a contracture. That's something that we'll have to reassess at her 30-day visit. At that point, if we're happy with where her MP joint is, and if the swelling and the bruising is resolved, we can then tackle her PIP joint with another injection if necessary. After Anne-Katrine's manipulation today, her Y cord she had an MP contracture of both her ring and small finger. With the manipulation today, we ruptured both cords. So the hope is that Anne-Katrine may not need any further manipulation or treatment today, and at her 30-day visit, once the swelling is resolved and she's been in that splint at nighttime in a fully straight position, that she'll be able to stop the splint and won't have any residual contracture at that point to treat. So we'll see Richard again at 30 days. At that point, we'll likely have much less swelling at that point, and we'll make sure that he's got a good correction of his index and middle finger MP joints. As long as those look good, we'll then take stock of the other areas of his hand where he still has contracture, PIP joints of his index and middle, and some MP joint contracture over on the ring finger side, and determine at that point whether or not he'd benefit from any further injections. So as you saw with the patients that we treated with Xiaflex, it's a great option for patients. It's been proven to be very effective. It has a good safety profile and tolerability, And patients have been very excited about the experience they've had with treatment of their Dupuytren's disease with Xiaflex as opposed to more formal surgery. Xiaflex is just one more option in a surgeon's armamentarium in order to get them through treatment and resolve their contracture in a less invasive way.
Xiaflex collagenase Clostridium histolyticum is indicated for the treatment of adult patients with Dupuytren's contracture with a palpable cord. Important safety information. In the controlled and uncontrolled portions of clinical trials, flexor tendon ruptures occurred after Xiaflex injection. Injection of Xiaflex into collagen-containing structures, such as tendons or ligaments of the hand, may result in damage to those structures and possible permanent injury, such as tendon rupture or ligament damage. Therefore, Xiaflex should be injected only into the collagen cord with an MP or PIP joint contracture, and care should be taken to avoid injecting into tendons, nerves, blood vessels, or other collagen-containing structures of the hand. When injecting a cord affecting a PIP joint of the fifth finger, the needle insertion should not be more than 2 to 3 millimeters in depth, and avoid injecting more than 4 millimeters distal to the palmar digital crease. Other serious local adverse reactions in clinical trials include pulley rupture, ligament injury, complex regional pain syndrome, CRPS, and sensory abnormality of the hand. In the controlled portions of the clinical trials, studies 1 and 2, a greater proportion of Xiaflex-treated patients, 15%, compared to placebo-treated patients, 1%, had mild allergic reactions, pruritus, after up to 3 injections. The incidence of Xiaflex-associated pruritus increased after more Xiaflex injections. Although there were no severe allergic reactions observed in the Xiaflex studies, those associated with respiratory compromise, hypotension, or end organ dysfunction, severe reactions including anaphylaxis could occur following Xiaflex injections. Healthcare providers should be prepared to address severe allergic reactions following Xiaflex injections. In the Xiaflex trials, studies 1 and 2, 70% and 38% of Xiaflex-treated patients developed an ecchymosis, contusion, or an injection site hemorrhage, respectively. The efficacy and safety of Xiaflex in patients receiving anticoagulant medications other than low-dose aspirin within 7 days prior to Xiaflex administration is not known. Therefore, use with caution in patients with coagulation disorders, including patients receiving concomitant anticoagulants except for low-dose aspirin. The most frequently reported adverse drug reactions greater than or equal to 5% in the Xiaflex clinical trials and at an incidence greater than placebo included edema peripheral, contusion, injection site hemorrhage, injection site reaction, pain in extremity, tenderness, injection site swelling, pruritus, lymphadenopathy, skin laceration, lymph node pain, erythema, and axillary pain. Please see full prescribing information and medication guide.